So to begin, in the world of clinical psychology, it simply does not get any bigger or better than Dr. David Barlow. He's an absolutely prolific writer with over 600 articles and chapters, 75 books and clinical manuals, cited over 100,000 times. He's trained countless students and postdocs, including luminaries in our field, such as Dr. Michelle Krask, who was here several years ago for a WKW, and Dr. Stephen Hayes, who went on to develop acceptance and commitment therapy. Dr. Barlow was the president of the Division of Clinical Psychology of the American Psychological Association, and also president for ABCT, the Association for Behavioral and Cognitive Therapies. And this year, he received the Gold Medal Award from the American Psychological Foundation for lifetime achievement in the practice of psychology. As a bit of background, he received his PhD from University of Vermont in 1969 and went on to be a professor at University of Mississippi, and then Brown, and then SUNY Albany, and in 1996 he moved to Boston University and founded the Center for Anxiety and Related Disorders and has been there ever since. On a more personal note, I still remember reading one of Dr. Barlow's books when I was a young clinical psychology graduate student nearly 15 years ago. At the time, the spectrum of different anxiety and mood disorders were all viewed as distinct disorders, with very separate manuals and treatments for depression or generalized anxiety or social anxiety or panic disorder and so on. And then suddenly, our class reads Dr. Barlow's chapter about a unified protocol, one which had the potential to help all of these different disorders. And it really opened my eyes. It was sort of an epiphany that there is this shared mechanism that unites all of these disorders of emotional suffering. And it's forever changed my view on the best way to go about researching and developing new treatments for anxiety. You're going to hear a lot more about this today. And we found out at dinner last night, he doesn't make too many trips anymore, but he decided to come to Tulsa, Oklahoma. So please, everybody, join me in giving a warm welcome to Dr. David Barlow.
Justin, for that warm welcome. Let me just say what a pleasure it is to be here. Justin's quite right that I have cut back a bit as the years have gone by, and you've heard there's been a lot of years that have gone by. But word has spread around the country, around the world to some extent, about the facilities here, certainly about the float tank. Yeah, I've had colleagues come and say, you know what they're doing in Tulsa? Yeah, and so it's sounded really, and it is really just creative and very groundbreaking, cutting edge. So it's just a pleasure to come here and be able to visit with you for a couple of days and catch up on what's happening. And as part of it, I'm happy to catch you up on what we've been doing for the past number of years. And that is looking to see if we can develop some new approaches to treating what we are increasingly calling emotional disorders. We'll talk more about emotional disorders in a minute, but basically for those of you who have been around on the longer side of things, not many would be around as long as I have, but you'll remember the old neurotic spectrum of disorders that goes back to early systems of classification and theorizing, and it included almost all non-psychotic disorders, leaving out the personality disorders and of course the psychotic disorders. And it's interesting that emotional disorders pretty much covers that same waterfront. Here's the obligatory COI. If anyone really wants to read this, I'd be happy to forward it to you later. So what are emotional disorders? Well, we start off by thinking, of course, of anxiety and mood disorders. And this is certainly the bulk of the individuals we may see in our various clinics, and I expect that's the case here as well. We know about these disorders as they had developed, as they were articulated, particularly beginning with DSM-IV and some of the later versions of the ICD. There was substantial overlap among the disorders, very high rates of comorbidity, the necessity of looking at constellations of problems in patients who certainly met criteria for severity, but somehow didn't quite fit into the specific diagnostic criteria, and we called them not otherwise specified or not elsewhere classified, or but they would be clearly have a problem that would be severe enough to warrant some intervention. And there were many sub-threshold presentations where maybe these patients with a lot of these symptoms, maybe some obsessional thoughts or some panic attacks or even some depression, but clinicians couldn't really judge or conclude that it was severe enough to meet the criteria for a disorder. So that was kind of a dimensional judgment, and we call those patients sub-threshold in their diagnosis. So there are all of these problems that were presented with the diagnostic system. And indeed, but before actually saying this, I don't want to say that I don't want anyone to think that I concluded that the DSM-III and this kind of nosological system that evolved at that time was a bad thing. It was not a bad thing. It was a very important thing at the time. This would have been 1980, because it allowed clinicians to actually, for the first time ever, reliably identify disorders, communicate with each other about these disorders existing, and most importantly, it spurred enormous research efforts around the world at further studying classification and nosology, and also treatments, both drug and psychosocial, for these disorders. So it was a very important step at the time. But what I'm saying is that then, as the years went by, particularly as we get to the 1990s, we began to discover with that research some of these problems with the great deal of overlap and the comorbidity and things like that. We would not have known that if that system was not devised to begin with. So here we are. And when we got to DSM-IV, which would have been the early 90s at this point, we, in nosology, in the science of classification, no matter what you classify, there's always two kinds of people, to quote the old bromide. There's, in this case, in nosology and classification, there's the splitters. These are the people looking for ever more narrow categories of classification that you can really, again, identify reliably and that share a few features. And then there's the lumpers, who say, yeah, but those are trivial differences. We really need to look at what are some of the underlying factors or properties that really are similar among groups of whatever groups you're studying. So in the case of diagnoses, we had our splitters and our lumpers, and while the field of classification is a relatively small field, not a lot of people studying it, nevertheless, these battles were taking place over the years. And we thought by the time we got to DSM-IV that this was the zenith of splitting. We would never continue to split because we had gotten too narrow already because of the problems I mentioned. And we would return to looking at the underlying dimensions of psychopathology, supporting brain circuitry and supporting brain circuitry. And of course, as you all know, we were not correct about that. Getting a little feedback there, I think. Let me try here. Yeah. So back in the mid-90s, when DSM-IV came out, As you can see, we went to just taking the anxiety disorders alone, we went from one class of anxiety disorders to 3 classes: anxiety disorders, trauma and related disorders, OCD and related disorders, 3 separate classes altogether. And we went from 10 to 23 diagnostic categories. And this was with 4 of them were entirely new. Some of them were migrated in from other areas, like from the dissociative disorders or the somatoform, we called them at that time, disorders, like illness, anxiety disorder. It used to be hypochondriasis. Some of them were entirely new, like hoarding disorder, some of the attachment disorders in childhood. So, and this was really, so I sat on that committee, that task force, and this was a task force that said, this is exactly what we do not want to do. We do not want to create more diagnoses unless there's a very high threshold. And so in DSM-IV, these were the changes from DSM-IV to DSM-V. So at the same time that this was happening, and DSM-V is going to be with us for quite a while, because it's such an effort to make these kinds of changes. ICD-11 just came out, and it's very similar in many ways, because there was an effort to coordinate the two. But at the same time this was happening, personality theorists were continuing to study the field of temperament in the laboratories, something that had been going on for 100 years at least. And there were many constructs that were in play and in the literature, and all of you have studied them at some point while you were in school and certainly afterwards. And you'll be familiar with the terms, neuroticism, behavioral inhibition, and the like. Several different kinds of behavioral inhibition. As I was saying today, trait anxiety, negative affect, these were terms that would be created by individual theorists and investigators. They would each have their defining differences. Certain aspects of these personality traits would be highlighted, and others that weren't on here. I was talking this morning about Cloninger's term of harm avoidance, which was another one that was popular for a while. And so, for example, Jerry Kagan at Harvard, his definition of behavioral inhibition in his young kids was a very biological kind of notion, and appropriate for the kids he studied from just after birth up till 6 or 7 years old. And it differed a bit from Geoffrey Gray in London's definition of the behavioral inhibition system. So there were some differences around these. But the bottom line is, when my colleagues and I began to look at these constructs, these personality constructs, they shared a lot more than what differentiated them. There was a lot in common. And we began looking more carefully at that. We began looking at the role of these constructs in the emotional, what we came to call the emotional disorders, and settled on the term neuroticism, the old Ising term, not neurosis, but neuroticism, simply because it was one of the better known terms that had been received perhaps the most study. Isaac himself, an interesting anecdote, who actually created this term, he was not happy with the term. Even in the 40s, iconoclast that he was, when he came up with this term, he said, it's too close to neurosis. And he wanted to be, he spent his life getting as far away from neurosis as he possibly could. But nevertheless, he thought it did capture the essence of what he was trying to get at. What is neuroticism? Is that me? Am I standing in the wrong place? That's all right. We'll try it here. Yeah. Somebody may not like what I'm about to say. So a consensual definition of neuroticism then would be this tendency to experience frequent, intense negative emotions, anxiety and depression, but not just anxiety and depression, anger, irritability, and the like. And the second part of the definition, associated with a sense of uncontrollability, unpredictability, perception of inadequate coping in response to stress or the experience of intense emotions itself. Now, we'll revisit this throughout the next half hour or so, because that forms the basis of a lot of what we say. So, strong, intense, negative emotions experienced frequently, and the sense that events, whether they're stressful life events or the emotions themselves, are not entirely in one's control. Uncontrollability, very central premise. This neuroticism construct predicts a great deal. It's a very robust variable in the world of psychopathology. This is just one example from our lab, my colleague Tim Brown, of showing that it is neuroticism, which is high, medium, and low neuroticism, in patients with GAD, that predicts all of the temporal covariance in the course of these disorders. So this is neuroticism predicting outcomes from people with high levels of GAD, with high levels of neuroticism. But if you reverse it and you say, what about the severity of the diagnosis itself? Because we rate, every time we make a diagnosis in our clinic, we rate the severity of it using our structured interview. The severity of the GAD predicts the higher order factor, predicts all of the temporal covariance. And Michelle Krask, who was here a few years ago, and her colleagues, Rick Zembarg, another one of my postdocs actually, who's been at Northwestern for a while now, and Sue Meinica in their groups, in their very important prospective study of psychopathology, found a lot of interesting things, but for our purposes here, the main one is that neuroticism measured at an early point in time predicted unipolar mood disorders, anxiety disorders, as well as substance use disorders. We'll return to that issue in high school students over time. And the unipolar mood and anxiety disorders were predicted more strongly than the substance use, and the combination of the two is predicted most strongly of all. So here again is a robust but common finding of the temperament actually being the seemingly premier kind of predictor of the onset of various emotional disorders. And there's many other studies like that. So where does neuroticism come from? And this is where it gets interesting to us, at least, because I was certainly taught, even way back when I was in school, as I'm sure most of you have along the way, that these are temperaments by their very definition. They don't change. They're supposed to be stable personality traits. That's why they're called personality or temperaments. They don't change. Emotions may change around them. So, and one of the questions is, where do they come from? These are fairly important constructs. What are the origins? So we've elaborated a theory called triple vulnerability theory that's evolved, first came out in the late 80s, but it's evolved over the years to try to account for the origins of not only emotional disorders, but neuroticism itself, as we've come to realize, and is composed, as the name suggests, triple vulnerability of three components. And we're going to focus on the first two, generalized biological vulnerability, kind of a heritable contribution to negative affect or neuroticism, and then a generalized psychological vulnerability that seems responsible for the development of this sense of uncontrollability, which is so much at the heart of anxiety and to a great extent depression. Sense that events are proceeding in an uncontrollable, unpredictable way, and I don't think I can cope with it. There's a third vulnerability, which we call a specific psychological vulnerability, which given the first two, which as you'll see in a minute, represent the origins of neuroticism in our view, then this one comes into play, reflecting early learning that might shape neuroticism in the direction of one specific disorder versus another. Panic disorder versus OCD versus hypochondriasis or whatever. But we're going to focus on these two for the moment, and simply in some summary slides, point out that it's been very well known for a number of years that there's a certainly identifiable, heritable component to the temperament of neuroticism, or any personality trait for that matter. But our behavioral geneticist colleagues have also been concluding for at least the last decade that this alone is not going to allow us to come up with a satisfactory system of nosology. The models on which they almost all agree is these polygenic models where a lot of genes are each making small contributions, alleic variations of common genes are making, in the aggregate, some contribution to temperament. And the best guess in terms of what's actually inherited is this kind of heightened generalized reactivity. So then we get to but it's obviously an important component. Then we get to the generalized psychological vulnerability, and this is one of the strongest and most robust set of findings over the past 75 years that you're going to find in psychology and even neurobiology. And it began in the 30s and 40s when the paradigms were called experimental neurosis, interestingly enough. And these were the paradigms from the laboratories of some of the early giants in psychology and physiology, as it was in those days, going back even more than 75 years, obviously. Pavlov, Masselman, Liddell. And basically, Sue Meinecke and Killstrom took a look at all of that literature way back in the late 70s, and what would happen if, just to refresh the memory, everybody had a bit of this in school, but in these experimental neurosis paradigms, they would take animals in the laboratory, and they would typically present them with insolvable conflicts, and where the food would be in the corner, but every time they went to it, they'd be shocked so badly they couldn't do it. It was a typical sort of thing like that, approach avoidance conflicts or other kinds of conflicts which were unavoidable and insoluble. The animals would slowly kind of deteriorate into a sniveling, shaking, to be anthropomorphic, anxious organism in a corner, defecating, and everything you would think would be, the animal equivalent of anxiety. And they called it, experimental neurosis. And Meinecke and Killstrom came along and said the common factor, and there was a number of paradigms, that was just one, number of paradigms like this. Meinecke and Killstrom came along and said what's common about these experiences is basically it's producing a sense of unpredictability, uncontrollability, inability to cope with the horrific, stressful events at hand. And future research showed, particularly by Sapolsky, studying baboons in the wild, and Steve Swamy at the NIMH, and many others, and that might be Murray, Stein, that these experiences, this early trauma, if you like, result in stable changes in brain function and even brain structure, and that these changes include the ability to turn genes on and off. So furthermore, and everyone, all clinicians, of course, are well aware that early trauma, seems to be clinically associated with a variety of disorders. The difficulty with the clinical observations is typically clinicians are looking very narrowly at their patient, and they might say, and they're looking very narrowly at the type of trauma, so they might say early sexual abuse seems to be associated with OCD. And you'll see papers on that. But when you broaden it out, it's really all disruptive early experiences, and it doesn't cause any one disorder. Okay? It causes seemingly this temperamental change itself, neuroticism. And furthermore, it's not just early trauma that seems to have this effect on functioning and brain function and structure. It's also other kinds of experience, such as certain parenting styles, and this draws from the very broad and deep literature from attachment theory, with which many of you are familiar, noting that certain parenting styles, particularly those where there are over-controlling, overprotective parents who are going to clear the way for their child, make sure they never experience any failure or discomfort. Boston, we call them snowplow parents. A popular term is helicopter parents, I think, something like that. And they mean well, but they'll often do it in a tense kind of way, this kind of attachment style. This also has the effect of producing this sense of uncontrollability, unpredictability in the child. Makes sense? These children never get to fall down and learn they can pick themselves up, experience failure, as every kid does, and begin to learn how to cope with it. They don't get the healthy attachment kind of experience of having a safe person over here, and they can venture out and begin to explore the world, knowing they can come back when they run into trouble. So these kids with that kind of a parenting style have reached their middle school years, and middle schools, I don't have to tell you, being an extraordinarily difficult time socially, inevitably run into the types of experiences that are overwhelming for them, and that can have the same kind of effect, particularly if it's these are lined up with the biological heritable component. So, and the consequence again is not any specific disorder. So I take issue, and I may get pushback on this, with the complex trauma people. It's not complex trauma, it's neuroticism. It's, or take any disorder and try to trace it back to a single kind of traumatic event. There are some cases where that might shape the phenotype, if you like, of the disorder, but we believe that most importantly is creating the kind of temperament that is fertile ground for the development of these disorders. Not that everybody with this temperament develops disorder, but there is certainly a necessary condition. This lining up of this biological and psychological heritability produces this, what's called the common neurobiological syndrome. Here we come to the Heidelberg excitability again, so the limbic structures. And this is a very well-documented set of findings, deficient pattern separation, meaning the cues that the generalization curve flattens out so that you get what's, they've called free-floating anxiety, but it's really responding to a lot of different cues. It generalizes widely and is found across all of the emotional disorders and neuroticism itself. Here we come back to the definition again. As I said, we would revisit it. And so our next step then in looking at our long-range goal of could we begin targeting neuroticism itself for treatment was to break it down into a set of constructs that already existed and that by and large were well studied. And of course, right on top is increased anxiety sensitivity. That arose out of the study of panic disorder, and I don't have to tell you here what that is, since this is one of the centers of the world for studying anxiety sensitivity. But it certainly, with patients with panic disorder and their exquisite sensitivity to interoceptive cues that might signal the beginning of the next panic attack, is very prominent clinically. And so that's where the study began. There's also decreased mindfulness of emotional experience, which we interpret as an avoidance of these intense emotions. Experiential avoidance of various kinds of situations, both internal and external situations, that might be represented by these strong emotions, and a lot of negative appraisals and attributions. So this next fact then, so those were kind of the constructs we began looking at. But in terms of developing a conception of the real function of emotional disorders, what's really happening in emotional disorders, it all began with our study of panic disorder. And this slide goes back to before a lot of you were born, 1985. And it was one of the first examples that we caught quite serendipitously of a physiological profile of a panic attack. Remember, panic attacks were very new in those days. You know, they'd made it into the DSM just in 1980, so 5 years previously, and biological psychiatrist, so Don Klein had begun studying them earlier than that, but it was still a relatively new concept. And well, I don't want to digress too much, but anyway, we began studying this, and what happened was we would bring our patients in, and this was a woman who happened to have panic disorder with agoraphobia, and we would routinely run them through a psychophysiological kind of paradigm in our lab, and this would more or less be a resting kind of hooked up to our polygraph in those days. But they'd go through several exercises, a cold pressure stress, you know, put your hand, we don't do that anymore, I don't expect, but put your hand in cold water, and mild stressors, we'd have them do serial sevens. And so we'd run them through some mild stressors. But one of the conditions we ran them through would be relaxation. Take some deep breaths, relax, muscle relaxation. And in a phenomenon we then shortly after identified as relaxation-induced panic attacks, which we were talking about yesterday a little bit with Justin, this woman, much to her surprise, which was what a panic attack was all about, in those days they were called spontaneous panic attacks because nobody knew what triggered them. Much to her surprise, but equally to our surprise, has a full-blown panic attack while she's hooked up to our polygraph equipment. You can notice a couple of things about it. First of all, this wasn't just something in her head, which many people suspected in those days. This was a massive sympathetic surge. You can see the heart rate more than doubling. Frontalis EMG, we had her on finger temperature, interestingly, going up rather than down, as some people might suspect. And the other thing to notice was that it was on its way down in about 3 minutes. The patients, that's different from many patients who say, oh my God, it lasted an hour. But in fact, typically it's over fairly quickly and it's on its way down, and they're reacting to the residual kind of consequences of having such an unexpected severe panic attack. So that was a panic attack. But there was another interesting feature we discovered about these panic attacks in that decade of the 80s, and that was they were very common. When we began looking closely at the occurrence, the kind of prevalence of panic attacks, many, many people had them. 15 or 20% of the population would have what came to be called non-clinical panic attacks. And a small percentage of those, 1 or 2%, would have them and go on to develop panic disorder. What was the difference? Why did some people develop disorder and others didn't? So we began looking at differences among these types of attacks, and we found that they were just processed very differently in these two groups of people, the non-clinical versus the clinical. The non-clinical people would make very different attributions about it. And they would say that stuff like, I'm just working too hard. I've got a new baby at home, and I'm working all the time, and I got to get some more sleep. Or it was that I ate too much steak last night. And, I've really got to watch my eating a little bit. I'm going to have to be careful of that. What's common in those situations is the implication that it's something they can control. Of course, it's not true. It's an illusion of control. They're not in control of these non-clinical panic attacks, but they make the attribution they are. Why? They don't have the neurotic temperament. They don't have that temperament, that fertile ground on which an event like that, an extraordinarily stressful event like that, can fall. What about the people who go on to develop panic disorder? I don't have to tell all the clinicians in the audience what they think. They think they're dying or going crazy, and these would call the ambulance, put a straitjacket on them, take them away. They may never come back. Particularly back in the 80s, they would think that, when very few people knew what a panic attack was. So it seemed like the point is that, and then you could see how in the diagnostic criteria, beginning with DSM-IV and then DSM-V, we accounted for that. But prior to DSM-IV, when we're making a diagnosis of panic disorder, we usually just count panic attacks. So we'd say, 3 in a 3-week period. Well, maybe it should be 4 in a 4-week period. And again, I was at the table. Some people say, no, I think it should be 10, a lifetime. And the problem was these were all, to make a diagnosis, you had to go back sometimes years. But what changed with DSM-IV is that it's not having the panic attack that's the problem. It's becoming anxious about it. And it's having that anxiety, which is a presenting set of symptoms, if you like. And having that anxiety be so overwhelming that it's interfering with your life, and that accounts for the severity. And those criteria made their way into DSM, persistent concern or worry about additional attacks, or changes in behavior related to the attacks. In other words, the kind of avoidance of all of the various cues that in their minds might bring on the next panic attack. So again, get that concept. It's not the panic attacks, which sort of was, it's called panic disorder, but it's not the panic attacks. It's anxiety over having additional panic attacks. So with that in mind, we developed a treatment for panic disorder back in the late 80s, Michelle Krask, and continued looking at that. But in the meantime, we're saying, then the years go by. We're saying, what about some of these other disorders? Is there anything like that, going on? Well, we began to identify, this process, this Laura Campbell-Sills dissertation, another San Diego person. We began to identify this process whereby, there were certain setting events that led to kind of really negative emotional reactions that patients reacted badly to. But then one of two things could happen. First of all, they could experience this very intense emotion, such as a panic attack. And remember, a panic attack is really just the emotion of fear occurring at an inappropriate time when there's nothing to be afraid of. So they could perceive them as acceptable as controllable. They would not engage in any kind of maladaptive emotion regulation or emotion dysregulation behavior, and their mood would recover naturally. But against this background, this toxic background of neuroticism, this temperament, which remember is kind of a stable state in the brain, the emotion is perceived as unacceptable, uncontrollable. It leads to all kinds of Herculean efforts to somehow prevent or avoid the emotion, prevent the emotion from occurring again, avoid circumstances where it might be triggered, or suppress it in any way possible. Suppression fails because, using some well-known principles of psychology, ironic processes, Dan Wegner's work, you are not going to be successful suppressing emotionally salient internal thoughts or feelings. It's not going to work. You've all tried the white bear phenomenon. Don't think of a white bear attacking you and stuff like that. That never works, and so it explodes in their head, and disorder develops. So that's kind of the model, and more. So can we extend that? The next step was, and this took place over a number of years, does this state of affairs characterize other disorders? So this is a new slide which we're working up now in a paper we've submitted and getting a lot of pushback. So we're trying to dealing with the thing. But we talked about panic disorder. And again, what is the setting event? Well, it's an unexpected panic attack. Where does an unexpected panic attack come from? We've already talked about the fact that it can be non-clinical or clinical. But where does it come from in the first place? Well, in fact, there's a very logical explanation. Panic attacks are simply a fairly common response to stress that runs in families, just like most stress responses. So if you tend to get tension headaches, chances are so does your mother or some of your siblings, and your kids might. If you tend to have a little kind of rumbling gut kind of thing when you get stressed, same thing. Maybe your dad has it. Your kids are going to be prone to it. These stress responses, these characteristic ways of responding to some environmental stress, run in families. They're highly familiar. Panic attacks, the same thing. If you've had panic attacks, non-clinical panic attacks, chances are good your kids might react to stress in that way too. But again, as long as otherwise you're psychologically pretty healthy, it's going to kind of roll off their backs. It'll shake them a little bit, what caused that? But they'll come up with make up some reason, and it will be protective. What about depersonalization, derealization disorder? This is another very common reaction people have from time to time. Feelings of dissociation. You can induce it. We induce it all the time in treating panic disorder because it's a common accompaniment of panic attacks. The problem is that you have some temporary feelings of unreality. The problem is they bother you. The problem is you become anxious about it. You fixate on it. And then you try to suppress that. And right down the list, perhaps most obviously, ego-dystonic intrusive thoughts. We've known for 50 years that under stress, unrelated stress, people will have the weirdest damn thoughts that you'd never want to admit to the person sitting next to you. frank sexual thoughts, mutilating thoughts. I mean, just thoughts that you would not want to make public. And what happens to most of us under those, and they'll increase and decrease with levels of background stress. What happens to most of us, they go in one ear and out the other, which is what we say to our OCD patients, but not with patients with OCD. If it falls on that fertile background of neuroticism and the kind of specific, I haven't talked about this yet, but that third vulnerability, the specific early experiences that might make that pop out as a phenotype. In this case, fundamental religious backgrounds, where you're taught thought-action fusion, that evil thoughts are as bad as doing something, as I was growing up Catholic in Boston. Not that Catholicism causes OCD, obviously, but in a neurotic context, and you have that is dangerous to have these kinds of thoughts, that's fertile ground for OCD. The problem is not the thought itself, again, even though that's the definition of the disorder. It's that it produces anxiety. It's very bothersome. So you see how this runs this is our concept that is running through these disorders. And you can run down these other disorders, body dysmorphic disorder, eating disorders. We extend this to eating disorders, and so on. Restless, unsatisfying sleep. If you wake up in the middle of the night and you say, oh my God, if I don't get more sleep tonight, if I don't get back to sleep, I'm going to be so horrible in the morning, blah, blah, blah. And then you're so worried about it, you don't get back to sleep. Some people say, oh, take some deep breaths, roll over, and get back to sleep. Everybody wakes up. Most people wake up during the night. The problem is, how do you react to it? So same sort of thing down. Borderline personality disorder, which we include as the queen of the emotional disorders, and so on. Trauma. Trauma, another one. Everyone's familiar with the data, the last one I'll speak about. Everyone's familiar with the data about all the people that experience the same trauma, but only a subgroup develops PTSD. Sometimes the trauma is extraordinarily mild by sort of general standards, and a PTSD will pop out of it. Other times, the most unimaginable torture, think of Senator McCain, no sign of any PTSD ever developing. And he's one of among 20%, of people who underwent that kind of horrific experience, but don't seem to develop PTSD because of it. So same kind of thing. So, given that unifying construct of emotional disorders, then I'll just run through the last bit quickly. This is where our unified protocol came from. It didn't happen in quite that neat a sequence, but this was the notion. Can we come up with targeting temperament specifically and directly? And the temperaments we're talking about is, of course, neuroticism, but also positive affect, extroversion. Talk about that in a minute. We came up with a protocol that had some modules of varying length, depending on the deficits that the individual patient would present with, in terms of how much of a dose of it they would get. We considered these yellow goldless ones to be the core modules. Emotional awareness training, making people aware of intense emotions, which, as everybody knows, with most of these people with emotional disorders, they are avoiding and suppressing. So we're bringing these emotions to the forefront, looking at their appraisals and attributions in a typical cognitive therapy kind of manner, dealing with the kinds of emotion-driven behaviors or action tendencies that these intense emotions drive. The most common example being the flight response, kind of automatic emotional flight response during strong fear. the other one being the fight or anger response if fear is not necessarily possible. The withdrawal and cognitive and motor slowing and depression. So we're countering those and also dealing with any kind of emotional avoidance. And of course, the main ones, the interoceptive awareness and tolerance, interoceptive exposure. And everybody here knows how that works. And then we fold that into some situational exposures targeted for the particular patient. These are the constructs we think we're attacking. Neuroceptive exposure, attacking the anxiety sensitivity that come out of this neurotic temperament. Negative appraisals, attributions, etc. And we feel that we're attempting to, that what we're doing that's important, pending further verification, is reducing the experiential avoidance and extinguishing the anxiety and distress that's become attached to these precipitating events and to the reaction to them. So we did this clinical trial. I'll just run through briefly. It's been published, but we took a lot of years to do, of course, as these trials do, but a large number of patients. We limited it to 4 diagnoses, not because we wanted to, but because we went back and forth fighting with our study section who said, oh, you couldn't include depression. That's not part of it. Oh, and then they say you don't want to include OCD. That is different brain circuits. We pushed back on the OCD. We gave them the depression. Anyway, it was a negotiation to come up with, what, what got included and what didn't. We treated 100 of them with our unified protocol, another 100 with our specific protocols, most of which have been developed in our clinic. So there was at least 20 in each of these diagnostic groups, got a specific protocol. And since there was 100, sometimes there was more than 20. And we had a wait list. This was an equivalence trial. So we're looking to say that the UP is at least as good as these well-established, evidence-based kind of individual approaches to these disorders. And these were the protocols for the individual disorders. And that's Edna Fowers on OCD. Rick Heimberg was at our clinic for a while, developing the social as a unified protocol. There's the consort diagram. Again, all of this is readily available to examine. And the results were basically that there was a difference in the number of patients completing treatment. I'm not entirely sure why, but we were more successful in retaining more patients in the UP. It could be because we had a motivational interviewing an MI or MEP module in there that the specific protocols didn't. Might be as simple as that we got a little more retention. Beyond that, though, pretty equal. This is just proportion no longer meeting a diagnostic criteria. For the principal diagnosis, no statistical significance there. For not only the principal, but comorbid diagnoses. This is where we thought we might see maybe some superiority of the UP, but it turned out to be, it looks like there's something there, but it was not statistically significant. Anxiety sensitivity, just to finish up with some of the other analyses, as nobody will be surprised to see that across all disorders, there was high anxiety sensitivity, and there were reductions in anxiety sensitivity across all disorders. And interestingly, the reductions from this analysis seem to be correlated with the onset of the interoceptive exposure. That's where they really seem to have a nice improvement. There's some brand new data I just threw in. This is just a recent sub-analysis. It hasn't been published yet, looking at the scales of the ASI. We're talking about that earlier, and showing that among the individual diagnoses, the intercept, which as you can see in these modeling terms is simply the baseline score pretty much, and that it was highest in panic disorder for the physical concerns, and panic disorder was significantly higher than the other disorders. And the social concerns were higher in social phobia, as you might imagine. Cognitive concerns. And then the rate of improvement. So the GAD what is that saying? Significantly lower than the diagnosed group with the highest estimated intercept is low. I understood this when I put the slide together a few days ago. But anyway, I think it seems to me the GAD and OCD for some reason did a bit better on the cognitive concerns. But there were some differences among individual diagnoses. I'll have to go back and read that again. Make sure I understand that. In terms of the slope of improvement. I also, just to finish up, we're now in the midst of adding modules to deal particularly with deficits in positive affect, which seem to run across a lot of the disorders and seem to be an important temperamental component as well. And that has now been published, this module. It's mostly dealing with our positive affect module is mostly dealing with the dysregulation of positive emotions. So we do savoring and stuff like that. It's not something that we're really dealing with the meaning of life or improving the overall quality of life or something. It's more just dealing with inappropriate positive emotion regulation. A lot of good reasons to think that's important. Won't go into all that now. The UP has had some additional applications across some of these other disorders. They've been published on bipolar disorder, where there does seem to be an enhancement of the basic medication regimen. The Renfrew Centers has adapted their protocol, I didn't mention this today, for eating disorders. And there's an article that just came out, I think, where it was a naturalistic study looking at their treatment as usual, and then the introduction of the UP, because they introduced the measures early, and found a nice bump. But it's not surprising because much of what they did was a total avoiding of any triggers, of any distress associated with eating disorders. Up until then, that was part of their treatment as usual. Borderline, my colleague Shannon Zavala is using the UP to treat the 80% of the borderline population that's not the most severe, not the top 20%, where they're in and out of hospital and attempting suicide, every week, but the 80% with strong borderline features that are less severe, and Marshall Linehan's collaborating on that. So, take-home message, we think we're ready to move beyond some of the disorder-specific protocols. Not that we necessarily are. The panic protocol, I was talking about with Saeed earlier, still remains very popular with clinicians. And clinicians who have been trained on it, who have used it, I think still prefer it when they have somebody with panic disorder. But generally, there are a set of principles that seem to me more broadly applicable that can be that form what we call a transdiagnostic unified protocol that should result in much easier dissemination, particularly for the next generation of clinicians. So thank you very much for your attention. It's been a pleasure again to visit everyone here in Tulsa. slideshow, we'll organize to get it delivered. Time for questions? So the question is, what's going to be involved in scaling up the protocol to disseminate it more broadly? And that's something several people are wrestling with. And so there are questions like, can we, for lack of a better term, dumb it down a little bit? Can we cut down the number of sessions? Can we make it more direct and simpler? And perhaps make it more amenable to even global mental health kinds of applications. That's going on now. The global mental, our colleagues in global mental health taking other common element approaches seem to be having some success doing that. And we're in touch with them. We've met with them in terms of would this contribute anything to some of their efforts, Vikram Patel and Laura Murray, and people like that working in different places around the world. And we have a project going on in Boston with, there's a very admirable, well-known organization, Boston Healthcare for the Homeless, from a guy named Jim O'Connell, who's an internist. And this guy is just a saint. But we're working with them to see if we can incorporate, again, a much simpler version of some of these modules for that population. We're working with the Visiting Nurse Association in Boston. There's a pilot study going on there and a grant application in. So it's in progress. How successful will we be? I think, remains to be seen. Yeah. Any other questions? Yes.
So the positive affect modules, so when you're testing like the efficacy of those, is it more, does this enhance positive affect, or is it, again, does this enhance remission rates, for example?
Yeah.
Compared to the module?
Well, so my student, Jenna Carl, for her dissertation, took a number of people, forget the end now, that completed our trial, the clinical trial, but who continued to be below a cutoff point on positive affect. So they still had low positive affect. And she took them and simply added this module. So they'd had the UP, and she added this module. And what she found, again, it just came out, and what she found was, yes, she could that is, increase the level of positive affect. And furthermore, it had further beneficial effects on their presenting disorder. So it looked, that's a general statement, of course, not every single person. But it looked, so it looked promising. One of the questions is, if you're going to come up with a truly kind of transdiagnostic module, well, maybe there are maybe you could put a sleep, and then where do you stop? And what is it that's not maybe covered well enough, and then where do you stop? And obviously there's a limit to that. You can't, and so one of the things we're doing is we're taking the 5 core modules, and we're also looking at individuals to profile them first. Say, do they need every module? Maybe they're, sufficiently endowed, if you like, with some of the skills for some of the modules. Maybe they only need 3, but maybe you could add a sleep. So can we personalize it and individualize it? So we have some data kind of being collected now, looking at that. Yeah.
So have there been studies comparing the UP delivered by a
No, that hasn't happened yet. Yeah, but it's an obvious kind of next step. We are in the process of digitalizing the UP. There's a company called SilverCloud. SilverCloud is it's an Irish company actually, that has done. They did Beating the Blues. Remember Beating the Blues? And so they're very good. They're very technically very good. So we are digitalizing it, and when that's done in a few months, somebody can undertake that. Not me, but somebody. Yeah. Yes, sir.
This almost sounds like it could be adapted like for an undergraduate skill training psycho-ed course or anything. Has anybody thought about working that direction?
Yes, I'm glad you asked that. There's and Robin is doing similar things.
Oh, sorry, Rob.
You know that.
Yeah, but yes, we have, as Robin knows, we have a little course that we piloted on a couple hundred of our BU incoming students, and it looked pretty good. Of course, with all of these things, there's very high attrition in terms of what they finish. It's all electronic. Now the university is very interested in that, so it's part of the incoming package, and that's just this year, and that's kind of just beginning. So we're collecting a lot of data on that, and there's somebody else running with that, and so I'm not clear on all the details of just how it's being implemented. But and there again, the notion is how much of it do you need? Well, you don't want the students aren't going to go through that whole thing, but they'll go. We have a 2-hour. Basically, we have it down to a 2-hour presentation, but we did that in person for the first time, and now I think we're doing something a little bit different. And now I'm forgetting what it is, but I'll have to find out. But it's kind of, I mean, it's sort of common sense. There's a lot of the college campuses now have the body programs, where an attempt to prevent eating disorders, distorted body image. And they're kind of introducing that to the freshmen, particularly the freshman women. And, trying to, and it's just for emotional health. It would seem like something like this has to be worked out, obviously, the details of it, but something like this probably should be in, the part of the package of beginning, of programs to work through freshman year, given the frequency of it. I mean, our student health center, I'm guessing most of them around the country are overrun by anxious and depressed undergrads, overwhelmed, dealing with all the things they deal with. And it seems to be, from all the data I've seen, increasing. Not clear why. Maybe it's just being recognized better, or students know there are resources to at least begin to inquire about. But, yeah. So it seems like just some kind of an emotional health program is going to be a great demand for that. Already is a great demand for it. Anytime it gets proposed that I've heard to colleges, universities, and their student behavioral health programs, they just can't wait to get something in if there's any data supporting it. Well, thank you again for your attention. It's been a pleasure.